Good afternoon, everybody. Sorry for the delays. Technology was playing up a little bit, but we've managed to find a way. Many thanks, Dr. Taka, for running the presentation. I'll be giving you the cues. My name is Joseph Kaziwe. I'm one of the registrars in cardiology. And for this presentation, sorry, we are running a little bit late, trying to make up for some time. 6 months ago, myself and my colleagues on the acute medical call received one of these patients who presented atypically from what we expected, and I wanted to share with you the journey of that patient this afternoon. So if we go to the next next slide, Dr. Taka. So for the case, we have a 60-year-old male presented through A&E through to the medical team. He was admitted with complaints of breathlessness. He was having productive cough, thick yellow sputum, and his past medical history, he had anxiety, nothing really much apart from anxiety. He was independent in his terms of his activities of daily living. Family social history, he was a non-smoker and was a social drinker, just like most of us would be. On examination, he was noted to be drowsy. His temperature was at 38.5 degrees. His saturations were 85% on room air. He had a coarse crackles on auscultation plus a mild expiratory wheeze. He had a tachycardia and a bit hypotensive, as noted, and he had no pededema. He had dry mucous membranes. So we proceeded on to manage this patient. I'm sure most of you, you will have seen such cases. If we could go through, use the chat function to see what your next step in terms of management of this patient. I'm sure this is a typical patient most of you, if not all, have come across. If you can use the chat box to tell me about the salient things in terms of the management plan that you'd be doing. Yeah, looking through the chat box. Okay. Dispense. Right. I can see everyone, it just seems those. You can see a message here. Right. Okay. Oxygen supplementation, fluids. Good. Okay. Let's go to the next slide. So the patient, as saturations are low, the patient was given some oxygen. You can see that he's tachycardic. His BP is on the lower side. He was given some IV fluids. If we go to the next slide, Dr. Taka, very good. So this is a typical case of what we would be doing, giving some oxygen supplementation, antibiotics, IV fluids, some paracetamol. Patient was observed. If we go to the next slide, investigations, as you would normally do, blood tests, we would usually send off some blood tests. The blood tests came back, revealed the CRP was about 100. The blood tests were shown as above. The UNEs, there was nothing much apart from being consistent with a bit of dehydration. Chest X-ray, clear lung fields, blood gas, pH 7.25. We can see the PCO2 is 7.5, the PO2 is 9.6, and the lactate is 1.5. So at this stage, if we can go through the chat box to see what sort of differentials, given the information that we already have, what sort of differentials would you be working with in case you're reviewing such a patient? So use the chat function. Yeah, CAP. I can see somebody with CAP. Very good. Very good. Let's go to next. I've only seen one response. Any other differentials there? So CAP is a very good one. It would be consistent with most of the things. COPD is another one, exacerbation that I'm seeing. I'm sure we have more than 2 people. COVID, yes. Somebody is on form with it. Yes, under the circumstances, COVID. Right, so looking at those differentials, if we see CAP, yes, it's a good one, but the chest X-ray is showing clear lung fields. So probably CAP comes lower. Normally in the CAP, we would expect to see some opacities on the chest X-ray. COPD exacerbation, potentially, we was getting some wheeze on the chest. COVID, yes, is also still a good one. The typical presentation of COVID, yeah, 6 months ago, COVID was there. That is true. Yes, typical chest X-ray, as you know, is usually abnormal. And the typical presentation is peripheral infiltrates on the chest X-ray. A PE, yes, that's a very good one. Yeah, so PE is a classical one that would also be presenting clear chest X-ray, respiratory failure. A few people get a bit of temperature. Good. CO2 retention in COVID. Okay, so that's another good one. So we've noted, if you notice a few things that do not fit in, we can see that we've got type 2 respiratory failure. I hope everybody is able to see that. Type 2 in regards to that fact that you can see the PCO2 is raised, 7.5. Looking at the blood gas, the PO2 is 6.9. So we have a type 2 respiratory failure. Typically, we are not seeing this in COVID. If we go back to COPD exacerbation, if we go back to the past medical history, this chap has no really past medical history of any significance apart from anxiety. He's a non-smoker. That is not to say that they can't get COPD, but it's also less likely. PE is a good one. Typically, they present with a type 1 respiratory failure. We can see there is a bit of leukocytosis with the CRP is raised. It doesn't still fit in very well. Anyway, those are good differentials. Let's move on to the next slide. So these are where the differentials that we're working with, similarly when we were seeing this patient. So somebody who mentioned COPD exacerbation. So we proceeded to give the patient some bronchodilators in the form of salbutamol, ipratropium, hydrocortisone was bringing a lot of thick mucus, yellowish. So we gave mucolytics. If we can use through the chat box, I've put there mucolytics. If we could have examples of mucolytics, if you're to see this patient, as I know you're seeing patients, examples of mucolytics you'd be giving. If we can use the chat box, please. And the mucolytics, so he's producing very thick yellow sputum. He's struggling. Glycopyrronium, carbocystine, yes. Carbocystine. Those of you who have gone through the respiratory ward, we also sometimes use normal saline nebulizers to help. Acetylcysteine, N-acetylcysteine is also used sometimes in ITU and sometimes also in the respiratory wards, but that's a very good one. Glycopyrronium, we shall come back to it. So he was given mucolytics, hydrocortisone, we've given fluids, we've given bronchodilators, we've given antibiotics, and we do expect that we've managed relatively well. We expect the patient to be improving. The patient, unfortunately, was not responding well and was getting more drowsy. Tip for anybody on call, if the patient is deteriorating, it means that we need to do further assessments. So we do a repeat gas, and the gas, as you can see, the pH is 7 now, 0.15. The PCO2 has climbed higher to 10. The PO2, we've corrected that because we're giving oxygen supplementation, as we discussed earlier. PO2 is of 14. The bicarb is 25 and base excess is negative 25. So at this point, we know that clearly our management strategy is not working and the patient is getting worse. So we ask for our colleagues in ITU to review the patient because the patient is in respiratory acidosis, is getting worse. He is ventilated and taken to ITU. If we move on to the next slide, please. So the patient is extubated after 24 hours. There is a role of NIV in extubated patients. He's given a bit of NIV for the next 12 hours and stepped down to our usual ward. By the time he stepped down, he's alert. His GCS is 15 out of 15. He's maintaining saturation as well, 96% on room air. He's got a good respiratory rate. We do a repeat gas, and the gas is fine. I've not put numbers because I'm sure that being enough to, you've looked at several gases and you know what the numbers are. We have, however, a problem of thick mucus that he's producing, and sometimes he's struggling to bring it out. So we kindly ask our chest physio colleagues to come and help with him. A neurological exam is done, and the neurological exam is all right. Nothing abnormal detected. 12 hours post step down, the patient goes into respiratory failure. He becomes unwell in similar ways. A blood gas is done, and it shows he's again in type 2 respiratory failure. We do the same things, but the patient is not improving. So the patient is reintubated. So at that moment, before we move on to the next slide, can I have a feel of through the chat box in terms of clearly we've thought about, initially we've seen this patient, we've thought about COPD exacerbation, we've thought about CAP, COVID, PE, but it's not going very well. Any other differentials coming through, if we can use the chat box. So myasthenia gravis, very good, seeing that. So we are starting now to think about other things. What is potentially going on? Something unusual is happening. Neuromuscular disorders, very good, very good. If we can continue, very good. So myasthenia, kyphosis, good, good. So we re-examine the patient. We now think that probably we are having a bigger problem. We have missed something. We need to change our strategy. If we move on to the next slide, Dr. Thacker, please. Very good. So just in line with what, other people have thought, we've revisited the history. When we revisit the history, we learned that he had been admitted for 3 days, 3 months before that admission. And the cause of the admission had been a chest infection. We go back to look at the gases, and he came in that time with a type 1 respiratory failure. Speaking to the wife notes that he'd lost significant weight over the preceding 6 months. They denied any history of falls, no family history of similar problems. We proceed in line with what most of you have thought to do the neuro exam. We check his power in the limbs, upper and lower limbs is all right. He's got normal tone. He's got no weakness. Eyes, he's got no ophthalmoplegia. Sensations are intact. Somebody said myasthenia gravis. GBS, I was expecting GBS to be coming through as well. No ascending paralysis. The muscle tone, as we said, was okay. Plantars were normal. Reflexes were normal. So at this moment, we are thinking of his lost weight, it's standing out. Could it be a malignancy? So we do a CT abdo-pelvis, and this CT abdo-pelvis is really showing nothing significant elsewhere, apart from mild bronchial ectasis. Now, okay, next slide. Right. That gives away the diagnosis. Further examination showed that his tongue was showing thinning and fasciculations, and more neurological examination demonstrated dysarthria of a certain grade. At this moment, through the chat box, can I see what people are thinking about and any other post-poll differentials? So MND, right. Okay, DMD, very good. So if we go one slide back, Dr. Thacker, please. One slide back. So at this moment, like people had already mentioned, it's important to look at different differentials. Myasthenia gravis, I agree with, that would be Kriaki, who's suggested that at this moment, it's important to have an idea of other possibilities. So MND finally is given away by the tongue fasciculations, as you've all rightly mentioned. But there are other differentials like myasthenia gravis, as you've pointed out very well. Other differentials that are neuromuscular. So there is another one that is a sister of myasthenia gravis. So we know that myasthenia gravis is a problem with acetylcholine receptors. We know that it is postsynaptic membranes that are being affected. Yes, yes, somebody has already given it out, LEMS. Somebody wants to write LEMS in full? LEMS in full. So that is the other sister of myasthenia gravis. It is presynaptic Lambert-Eaton syndrome. Thank you very much. So part of the reason why we did a CT is actually we were thinking, is it a paraneoplastic syndrome? As Gabriela has rightly mentioned, Lambert-Eaton syndrome, just a recap, is another of those paraneoplastic syndromes noted normally in small cell cancer. And in this condition, we have antibodies that are fighting the cancer that attack the presynaptic calcium voltage gated channels and cause weakness that is in some ways similar to myasthenia gravis. It's important to remember that with myasthenia gravis, we are looking at postsynaptic. In LEMS, we are looking at presynaptic. And that forms in very well with fatigability. So one of them makes, with with repetitive exercise, one becomes better and one becomes worse. Through the chart again, could we say which one becomes better? The fatigability, they become stronger on repeated exercise. Which one would that be? Lambert-Eaton? Will that be myasthenia gravis? Through the chat box. LEMS better, myasthenia gravis worse. Very well, good. So that is exactly true. So myasthenia gravis, we know that they get worse, and that is, whereas for LEMS, they become better. And the reason for that being, one is presynaptic, one is postsynaptic. In LEMS, because it is presynaptic, the postsynaptic side is acting very well. And if you, with repeated stimulation, you'll get enough acetylcholine to reach the postsynaptic, and you'll have good response. So the CT did not show. One of the things we looked at was for cancer. We're seeing a bit of bronchiectasis. If we go to the next slide, Dr. Tucker, please. So we've said the neuro exam. We are seeing tongue thinning. We have fasciculations and a degree of dysarthria. Right. So next slide. So we have our diagnosis given away as motor neuron disease. So today we hoped we can also have a look at, there is several diseases that can be giving problems with several neurological disorders that can give problems to the respiratory system. And one for this patient particularly was motor neuron disease. Wanted to have a recap of motor neuron disease, what it is, what it's not. Motor neuron disease is defined as a group of, well, when it comes to definitions, there are many different definitions that we can get. But I think the salient issues that I've picked up here are one, it's a group of disorders. They are chronic. They can be hereditary. If they are not hereditary, they are sporadic. They are neurological disorders, and they are characterized by progressive degeneration of motor neurons. They can affect the upper motor neurons. They can affect the lower motor neurons, or both. So this is how MND has been looked at traditionally. There are different types of the same disorder, on the full spectrum. So again, if you can use the chat box to see if people are aware of any different forms of MND that we are aware of through the chat box. Trying to see through the chat box. Any forms of MND people might be aware of? ALS, very well, thank you. That is Lauren, thank you. Any other forms? Okay, very good, Sam. Okay, if we move to the next slide, Dr. Tucker. So we've seen like ALS, somebody has talked about it. We have the amyotrophic lateral sclerosis. We have the pseudobulbar palsy, somebody has mentioned it. We have other types that have not been put on the chart, like progressive muscle atrophy, primary lateral sclerosis, and the bulbar palsy. Now, it's important to note that this is just another classification of MND. We had the earlier one classification is whether it is hereditary or sporadic. We can also classify them depending on the progression of the disease, which muscles, the nature of the neurological deficit, the nature of the primary neurological deficit. If we go on to the next slide, please. Most of you will be aware of that person. In the chat box, shall we check if anybody knows, recognizes that person? One of the famous people to have suffered from MND. Through the chat box. Very well. So Stephen Hawking, one of the famous people who is said to have suffered from, unfortunately, from MND. If we go to the next slide, there are many other people, but I think I picked that one for us today. Now, in terms of the different types of MND, I have drawn, I've looked at different models, and this is what I've adapted for this talk. So what you're seeing there is my handwriting when I'm a bit relaxed, when I'm not on call. When I'm on call, it's probably worse. So the relevant anatomy to try and remind us of the different classification of the MND. So we can start off from the motor cortex, seeing from the motor cortex on your right-hand side. We know that MND is primarily a disease of the motor nerves. Well, historically, it's been described as that. We shall discuss further down the line whether how entirely that is, how it is entirely true. So if we look at the motor tract, it originates from the motor cortex. If you see on the right side, we have the motor cortex. We have nerves coming from your motor cortex, like Broca's area, coming to the midbrain, that is MB. They move down to the pons. They move down to the medulla oblongata. I've put in brackets 9th to 12th. We'll come back to that. If we follow that line, they come down to the dotted line, that is the line of the decussation, and come down. So that CST, that is the corticospinal tract. So they move from the cortex, where we put the motor cortex, into the medulla oblongata, into the spinal cord, where they decussate until they reach the anterior horn, which is described, noted as AH. And then we have the peripheral nerves coming from the anterior horn to the target muscle, whichever muscle that is. So the red shows the peripheral nerves from the anterior horn, the lower motor nerves coming from the anterior horn to the muscle. So any deficit from the anterior horn, which is marked as red going forward, that is described as lower motor neuron lesion. Whereas any deficit, any problem in the tract put there as CST, which is the cortical spinal tract, will give us upper motor neuron lesion sort of behavior. Now, looking at the other side, we also have what we call the bulbar tract. So we are looking at the bulb, which is mainly the medulla oblongata, We know that the nuclei for the last 4 cranial nerves coming from there. So I've put down that dot cranial nerves, that's the blue dot. We know that it houses the nucleus ambiguous, that is serving cranial nerves 9, 10, and 11. We know that also the hypoglossal nuclei lies in there. So we have the tract named as 4. We have cranial nerves marked as 4 coming off from the medulla oblongata to the different muscles that they innervate. Any lesion targeting the tract 4 will give us lower motor neuron lesions of the bulbar system. We move on to 5. We know that these nuclei, that although the cranial nerves have their nuclei in the medulla oblongata, we also know that on the contralateral side, they mainly we also have what we call the cortical bulbar tract, that is in green. So they will receive innervation from the contralateral side, that is 5, into these nuclei, just like the other corticospinal tract was. And lesions in there will give us the pseudo-bulbar lesions that are more mimicking the upper motor neuron side of things. So looking at that system well, the primary deficits in MND can be derived from here, starting from number 1. If we have a lesion that is attacking the nerves from the anterior horn to the target muscle, that is 1. It's called progressive spinal muscle atrophy. That is where the lesion is, and they will be presenting predominantly with those issues. So we know it is going to be lower motor neuron. So in the tract, if we expect a lesion in 1, we know that it's going to be lower motor neuron lesion-like. Could we, if using the chat box, could we have a few of the characteristics we would expect in an injury to 1? There will be weakness. Which form of weakness? A lesion to 1 will give us lower motor neuron lesion behavior. Which kind of things? What's going to happen to the reflexes in 1, damage to 1? What's going to happen to the tone? What sort of weakness are we going to have in the muscle, that target muscle? Could we have a few responses through? So reduced reflexes, low tone, very good. Signs of lower motor, yes, signs of lower motor neuron lesion. That's what we are asking for. So reduced reflexes, yes. Low tone, yes. Weakness, do you expect spastic or flaccid? Yes, flaccid. Polly, thank you very much for that one. So if we have a damage to number 2, that is the corticospinal tract, we expect upper motor neuron lesion, yes. So we would be expecting, so that is number 2. You can see on the side where I've written primary lateral sclerosis, and that will give us upper motor neuron lesion form of features. So in terms of weakness, this time, instead of flaccid weakness like Polly mentioned, we're going to be having spastic weakness. In terms of tone, we do expect hypertonia. In terms of reflexes, we do expect exaggerated reflexes. Okay, very well. So that is primary lateral sclerosis. Then if we have a lesion that is involving 1 plus 2, that gives us the amyotrophic lateral sclerosis. Lesions combining 1 plus 2. That is why I named it number 3. That is a form of lateral, form of MND, and that is, yeah, thank you much. Thank you so much, Dr. Taka. Spastic versus flaccid rigidity. Very good. Very good. So number 3, if you add 1 plus 2, you get 3, which is the amyotrophic lateral sclerosis. There is magic in that number, in the sense that it is a combination of both, but also in the sense that it is the most common one in terms of prevalence. We'll find there's a classical question. It combines both upper and lower motor neuron lesions. So if we move to 4, we can see Bulba palsy. So what we do expect is lower motor neuron lesions, but of the bulbar muscles. So it is going to be the same as the previous tract, but this time we are talking about bulbar, lower motor neuron side from the bulbar muscles. Now, when you talk about bulbar muscles, we are basically going back to the medulla oblongata, and we are talking about muscles of swallowing, the tongue, we're talking about the pharynx, we're talking about the epiglottis. So we'd expect lower motor neuron lesion clinical features. If we have a lesion affecting 5, then we shall be getting pseudobulbar palsy. And that is the relevant anatomy. So the relevant anatomy of the different forms of motor neuron disease. Now, at this point, I should mention to you, I find this the most simple one and most simple way to remember the different forms. At this time, I also should mention that classically, historically, MND has been known as affecting motor nerves strictly. 2, there is an overlap in the different forms. So when we say, for example, progressive spinal muscle atrophy, a degree of them down the line can probably actually get upper motor neuron signs as well. We shall be exploring that as well. Now, before we leave this sentence, before we leave this slide, not sentence, can we again use the chat box to look at if people can give us a few differences between bulbar palsy features and pseudobulbar palsy features? We've gone through 1, 2, and 3, the first ones, in terms of what we would expect when what to do with the limbs. In terms of bulbar palsy and pseudobulbar, could we have a bit of typing in the chat box? Things that we can use to differentiate whether it is bulbar palsy or pseudobulbar palsy. Okay, it seems the chat box is not working very well, but just to go back to that anatomy that we talked about. So I've put there 9 to 7, that is where the cranial nerves, their nuclei are there. So 9 to 12, going to the muscles of, swallowing, talking. So it is important to note that in the bulbar, it's called the cortico-bulbar tract. From the motor cortex, there is also supply to nerve. We use nerve 5 and nerve 7 to help us distinguish. Whenever there is a bulbar tract, cortico-bulbar tract lesion, it also includes nerves 5 and 7, whereas in the outflow, that is the lower one, that is 4. If Dr. Taka, you put your cursor around, that is the bulbar tract outflow. It does not include 5 or 7. So in terms of the differences, remember that 4 is going to give us lower motor bulbar signs, whereas 5 will give us upper motor bulbar signs. So if we look at, for example, the gag reflex, if there is a bulbar palsy, we expect it to be absent, whereas we expect it in the pseudobulbar to be increased. If we look at the tongue that is being innervated by those muscles, if it is a lesion in number 4, which is in the bulbar outflow tract, we expect a lower motor neuron lesion. As such, we would expect the tongue to be wasted and to have the fasciculations. But if the lesion is in the cortico-bulbar tract, named as 5 there, we expect the tongue to be not wasted and to be spastic. If we look at the jaw jerk, that is one of the other things we talked about, reflexes. If we look at the jaw jerk, we expect it to be normal in bulbar palsy in number 4 and to be increased in the cortico-bulbar tract lesion. If we look at speech, that is one of the things, dysarthria, a problem of producing the words. It is not a language disorder like dysphagia. That is, I suppose, the previous speaker must have talked about it. That is a different area, a different problem with a language problem. So with speech, because the muscles in bulbar palsy, because the muscles are flaccid, remember that we get from each side, from the green one, we get you get supply, innervation from both sides. So if you have a unilateral lesion, we get the raspy voice. Whereas if you have both bilateral lesions, we get a nasal speech. Whereas on the pseudo side, if it is lesion number 5, we get what we call spastic dysarthria, aka the Donald Duck speech. Nasal regurgitation is another one that is used because the muscles are weak. There is usually nasal regurgitation in the Bulba Palsy, which is not usually seen in the pseudo-Bulba Palsy. Now, lastly, they talk about emotions. There is something called emotional incontinence, also known as pseudo-Bulba affect. It is also something that some specialists say happens in pseudo-Bulba, but is not seen in the Bulba one. And the reason for that is we'll be coming to that point later on down the line. Emotional incontinence, things like, exaggerated laughing followed by excessive crying. There is an overlap, but these are things that are happening in the brain, in the corticobulbar tract, that they are affecting other areas. So there is associations between corticobulbar tract lesions and conditions, the other degenerative conditions like FTD that are related, that have a similar spectrum of signs and symptoms. So if we go to the next slide. Right, so this is etiology. So in terms of etiology, I think the main thing is, one, the cause of MND is not known. It sounds a bit controversial, but there is different hypotheses. There is a lot of evidence that is coming in from different researchers, different specialists, and there is a genetic basis, especially in the hereditary one. There is a talk about different genes, like the ones that I've listed there. That one is a chromosome 9 gene. The rest of the words, the rest of the RFT2, I don't remember them, but they are different genes. They are different proteins that are being studied and are being implicated in, especially in the genetic forms. Remember, we said we have the hereditary one and the non-hereditary one. So the non-hereditary one is, the hypothesis, the working understanding is that there are cytotoxins that are associated with it. There is some insufficient evidence that, it is related to athletic childhood. Cigarette smoking has been implicated. Military service is something that has also been proposed. Evidence is not very good, but basically it's things that can damage the brain. For example, even boxers like posterior Parkinson's, damage to the brain that think is causing those problems. There is an overlap, but the general saying is that we don't know what causes it. On the next slide, please. So epidemiology, it is MND is a disease usually of adulthood. It is not exclusively to adults. I think the peak age is in the 50s to 60s. They are different. The most common one is the amyotrophic lateral sclerosis, which was shown as number 3, if you remember on the previous drawing, my adapted drawing. And I was, like I mentioned before, 1 + 2 equaling to 3. It has both features. So intuitively, in amyotrophic lateral sclerosis, you have both upper and lower motor neuron lesions. I think it makes sense that it has a bigger prevalence because you expect a mixture. So when it comes to epidemiology, it depends on the population you're looking at, which people are being studied. But on average, according to the Office of National Statistics, in the UK, we're looking at 66 in the UK population for amyotrophic lateral sclerosis. Progressive bulbar is the one that follows with about 25%. progressive muscular atrophy, about 10, and the last two, sharing the other burden. Also noting, maybe we can use this for the chat box. So we said the other classification is we have hereditary and non-hereditary. So we will look at the hereditary. Which one do we think hereditary and sporadic? Which one appears most? Which one has a higher incidence? Which one has a higher prevalence? So we can use the chat box. You can just put in hereditary more or sporadic more. What do people think? I should mention that prevalence and incidence, just to remind us that they are slightly different. They are related, but not really meaning the same. Prevalence being the number of people with MND at a particular line at a particular time, whereas incidence is the number of new MND diagnoses within a given time. So we could use them. They both have, there is a correlation between, for MND, there is a good correlation between incidence and prevalence. The chat box doesn't seem to be working very well. Shall we have a feel of what people think in terms of which one do we see more? Hereditary versus sporadic MND. So sporadic. Okay, I think I need to pose the question. Which one has a more prevalence? I think, yeah, I can see sporadic. Yeah, so I would have to agree with Polly, Lauren, and Tim Cantor, plus Maggie Robinson. Yeah, that sporadic, the numbers keep on varying, but generally speaking, sporadic is like at 85%, and hereditary only accounts actually to this accounts about 5 to 15%, depending on the populations you're seeing. And this is common to the different continents. We have more sporadic MND compared to the hereditary one. So the first question usually I remember they used to use, if there is a suspected case of MND, you want to know if there is a family history, which is very good. But in terms of the yield, in terms of the negative predictive value, it is actually not very good. Our patient, if you remember, did not have a family history, but probably it's not surprising given that it's only 5 to 15% of people who have a family history. So it is very still, MND should remain suspected even without family history, because actually its family history accounts for a smaller proportion of MND. So if we go to the next slide, please. Very good. So according to the Motor Neuron MND Association, the UK one, they tell us that the lifetime risk of everyone is about 1 in 300. That is the lifetime. So if we have 1 in 300, that is the lifetime risk for everybody. Everybody can get it because of the sporadic nature. In terms of the prevalence, that is how many people are having MND at a particular time. So the prevalence, according to the MND Association, most recent data puts it at 5,000 people living with MND in the UK at any time. Now, the incidence is actually higher than that, but many people with MND don't live for long. So you find that at any one time that prevalence has been the same, just because even if many cases are being diagnosed, many are also dying at probably an equal rate. So it's not offsetting the prevalence. Unlike other conditions, for example, say diabetes, where people live forever, incidence just keeps on accumulating the prevalence. It's slightly different for MND. If we move on to the next slide, Dr. Tucker, please. Very good. So the next slide is another one of my favorite. So we've seen the tracts. We've seen that there is a lesion. We've seen that, MND, the more more males get it compared to females. It's usually in the adult age, 50 to 60, the maximum, where most people get it. But then what exactly happens in MND? Again, I should caution that there are different hypotheses that have been put forward in terms of why the motor neurons die. But one of the common ones that is widely accepted is the one that we're going to discuss briefly. So I'm going to start with moving from your left. Well, we'll start with the motor neuron. You can see that the motor neuron has been labeled there very well. We have the microglia that we know are in between the motor neurons, and we have the astrocytes. So we know that the microglia are immune cells in the central nervous system. We know that the astrocytes are also placed within there. So what we do have is starting from your left-hand side, where you see number 1, we have, if you see number 1, we've documented it, is where it's labeled as glutamate-mediated excitotoxicity. Now, we know that transmission between the nerves is mediated by the glutamate. So as glutamate moves from one of the nerves, if we see where glutamate is, from one of the nerves across the synapse, we have glutamate controlling the transmission between the motor nerves, where we have number 1, when glutamate reaches the postsynaptic end, we then have the calcium influx in the motor neuron, and that generates an action potential that is propagated down the motor neuron. So one of the hypotheses is about inclusion bodies. Now, these inclusion bodies, I've put them on your left. If Dr. Taka, you can put a cursor around them. So the common ones are TPD43 SOD inclusion bodies up there. Yes, inclusion bodies. So the common hypothesis, and this is very true, especially in inherited MND. So these proteins, what are inclusion bodies? They are just abnormal proteins that have been noticed on histology to be accumulating in the motor neurons. So there has been good evidence that about 97% of people with MND have a lot of these inclusion bodies, abnormal proteins that have folded in an abnormal way in their motor neurons. Some of them are shown there. So what we do have is we have the yellow, as you can see, protein aggregates in there that are accumulating, protein aggregates, yes, that accumulate in the motor neurons. Now, when we have abnormal folding, remember proteins, we have things like transmission, normal cell function is all regulated by proteins. These proteins are all coded for through the messenger RNA, the DNA. If you have abnormal folding, it implicitly means you have abnormal function because of the receptor and the target. We have the target and the receptor. You cannot form good function. So what we do have is these abnormal proteins accumulating, not functioning, and killing off those motor neurons. So we start from 1. We have glutamate going in there. When glutamate goes in there, we go to mutant protein aggregations to prions. So there is one theory for genetic that supports the genetic transmission is through these proteins. Other theories suggest, like viral infections for sporadic MND and prions. These are still abnormal proteins that accumulate. They have the capacity. If you see number 2, these proteins have the capacity, like prions, we know, move from one cell to another. They can kill off one cell and then go to kill off another cell. So if you see prions in number 2, moving out of one cell, they can attack other cells. And these are thought to be environmentally mediated, either through smoking, through viral infections. The exact cause is debatable. But what is known is that they move out of the cells they've damaged and they can attack other cells. So we have a protein aggregate or a prion attacking a microglia. That is the defense system of the nervous system.
Once they attack them, they are able to change their function. So they alter the glial metabolism, they make them release noxious chemicals that cause neuronal damage. So you have the microglia attacking the nervous system itself through release of the noxious systems. Now, the nervous system damages the motor neuron. Number 3, if we can see number 3, it can damage it directly. They cause inflammatory release of damaging chemicals, but causing cell death. But also, if you sit down, they also have the ability to attack the astrocytes. Now, the function of the astrocytes is actually to get rid of the glutamate that is used in the transmission across the synapse. When we have glutamate accumulating in there, it causes excessive intake of calcium at the postsynaptic end, which causes death through exocytotoxicity. If we have number 3, if you come back to number 3, astrocytes dying, it means that the glutamate that has been released from the presynaptic end can no longer be taken up. As a result, continued release of glutamate leads to accumulation of glutamate and increased calcium influx. A lot of calcium is going to end up damaging the motor neurons as well. So we have glutamate-associated, glutamate-mediated death of the motor neurons, but also we have microglia through prions that attack the nervous system. It is not clear through this hypothesis why this attacks the motor neurons alone. But that is the hypothesis that is used. Now, I mentioned earlier on that traditionally or historically, MND has been described as to affect, is to be restricted to motor neurons. That seems to be changing with time as the more information comes out. This hypothesis is also used to explain the finding of these inclusion bodies. Similar inclusion bodies are being found in different conditions. For example, frontotemporal dementia, FTD. The same proteins are being found in them in the cells in the cortex in FTD, and it's thought that they are related. There is also increasing evidence that people who have MND, actually, there's a spectrum that has also about 30% end up also having frontotemporal dementia. Traditionally, we've also thought that MND, it affects all muscles, but it spares some. For example, muscles of the eyes are spared. Earlier on, we talked about myasthenia gravis and the Lambert-Eaton. In our examination, if you remember, you expect ophthalmoplegia, you expect diplopia. Our patient did not have any of this. Now, in patients who are having respiratory failure secondary to neurological deficits, as people had earlier on mentioned, remember, eyes are also a very good indicator. You expect a bit of diplopia, ptosis in some of the conditions like neuromuscular conditions, conditions of the neuromuscular junction like myasthenia or Lambert-Eaton's, but you don't see them in motor neuron disease. Among other activities, other muscles that are not affected typically, well, historically, as we've known, muscles of sexual function. So sexual function is remains intact. In fact, if anybody has watched, there is that movie on Netflix. Now I'm forgetting the name. The one of Stephen Hawking. If somebody remembers the name, you can type it there. Theory of Everything. The Theory of Everything. If people haven't watched it, you can watch it. It tells you more about his journey and some of the, he continued to sire kids even after his diagnosis. They don't get incontinence. Both of the anal or the urethral, the sphincters remain intact. That is also another thing that is peculiar to MND traditionally. The other thing we've talked about is the eyes. Those are also spared. Good. So if we move to the next slide, please.
I'm mindful, Joseph, we have overrun by about 5 minutes. So, and some people have left. I don't know how you want to proceed forwards in terms of summarizing?
Yeah.
Okay. Thank you.
Thank you very much. So what we've discussed before will inevitably, I should mention that we are able to finish in the next 7 or 10 minutes. I won't keep you here for long. Yeah, Dr. Thacker reminded me I won't overrun by more than 7 to 10 minutes. So what we do from the discussion we've had, what we end up with is we have cells that are getting sclerosis from a lot of calcium influx, a lot of damage from the defense system, the microglia, and we have sclerosed nerves that are unable to work on the muscles to cause contraction, and therefore causing the issues the symptoms we described earlier on. If we move on to the next slide, please. So we look at the history and physical features in ALS, and these are mainly going to lend themselves to what we've already discussed as the premise for upper motor neuron lesions versus lower motor neuron lesions. So if we look at, for example, ALS, which we already defined, we know what ALS is, the combination of 1 and 3. So we expect hyperreflexia, spasticity, as we talked about. We typically lower motor neuron manifestations, they come on as the disease progresses. It's important to note that there is usually asymmetry. We have other features that are related to CO2 retention as the breathing muscles are impaired. So, things like headache due to CO2 accumulation, confusion, inability to rest well. And I've put down there that there is increasing evidence that MND is not restricted to only motor neurons. There is a good proportion of people with diagnosis of MND that are coming in with features that are similar to like FTD. And one of the hypotheses is because they have the same histopathological proteins when they look at those subsets. If we move on to the next one, please. So if we look at the primary one, myotrophic one, aka the lower motor neuron phenotype, although they start as lower motor neuron in terms of phenotype, we've already mentioned that they can. It's a whole spectrum. 20 to 30% within 5 to 10 years have been noted to develop upper motor neuron features as well. Primarily, they begin off with progressive flaccidity. And then in terms of reflexes, we've already discussed that the reflexes, you expect the reflexes to be diminished. Fasciculations, we talked about it. Asymmetry is very clear. And in terms of atrophy, it is mainly in the distal limbs. However, this type has a better prognosis, and that's why we see, as we said, 5 to 10 years. People with the ALS usually survive 2 to 3 years post-diagnosis, but with PMA, they can survive 5 to 10 years. And by that time, as you can see, they are developing upper motor neuron lesions features, and that also leads to their death. If we move to the next slide, please. So we look at the treatment, management, how is it managed? In terms of treatment, again, the line is there is no specific treatment for MND, as you might be knowing. However, there's been drugs that have been found to have a role in terms of disease modulation drugs. If we move to the next slide, please. So the commonest, these are disease-modifying drugs, the commonest being Riluzole, which is an MDA receptor antagonist. So if you remember from our slide that we started with, the one that showed us the pathophysiology, we have glutamate-mediated toxicity, too much glutamate being released at the synaptic area, leading to a lot of calcium influx into the motor neurons that causes exocytotoxicity. So by reducing, Riluzole, generally speaking, is an anti-glutamate drug. By reducing that glutamate that is being released around the synaptic area, you're able to regulate the influx of calcium. So it does that through the presynaptic voltage-gated sodium channels. So it reduces the amount of glutamate that is being produced. And as we've said, excessive glutamate, we know that if you have excessive glutamate, you're going to have excessive calcium influx and a lot of death in the upper and lower motor neuron exocytotoxicity. On average, it's said to be delaying progression of the disease. Benefit is said gives them an extra 3 months. There is evidence that it increases tracheostomy-free survival, and there is the dose. I doubt that you'll be prescribing it very soon, but if you choose to, the dose is 50 milligrams BD. Next slide. Edaravone is another one that is premised on the antioxidative side of things. It's being used, but not a lot, not widely as Riluzole. If we move on to the next slide, please. So the mainstay of management is actually supportive, and I put SDT there. It is really symptom-directed treatment that is given to most people in MND. And this is the cornerstone for the management in MND. Next slide, please. So I've tried to bring out, the symptoms classically, what we do expect, like spasticity, the things that are being used, like there are tools to measure spasticity, to have a bit of objectivity. And I've put the different tools that are used there to see how people objectively are responding to the different treatments. Drugs are being used. I think the one that we commonly all know is baclofen. It's not only limited to baclofen. There is tizanidine that is being used, benzodiazepines. There are also non-pharmacological methods to manage the spasticity, for example, physiotherapy. If we move to the next slide, please. So Cialoria, this is really, we know that in MND there is impaired pharyngeal, the muscles of swallowing are impaired. So there is a problem with the saliva being swallowed and causing problems. There's a problem. So a lot of saliva being produced, and the regulation of its control is being lost. So there is a lot of aspirations from the saliva. So to manage this, the drugs that have been found to have, a lot of use are anticholinergic drugs. Somebody talked about glycopyrronium earlier on, so that is very useful in this case. I think they must have known what the diagnosis was before even we moved there. Atropine, that's very useful. There are treatments that target the salivary glands, for example, irradiating them or injecting botulinum toxins in them. There are other ways of like chest physio, giving mucolytics. We've already talked about which mucolytics can be used. Chest physio that can also help with expectoration of the saliva and sputum. If we move to the next slide. So dysphagia, this is another symptom that is also related to mortality. So if people actually have one of the poor prognostic signs in MND is bulbar involvement. So you have problems with swallowing. People commonly die of aspiration pneumonias. So to target this, there are things that can be done. For example, when you're feeding people dietary changes, and what dietary changes, change the consistency of food to lower the risk of, aspiration. This does not take it away, but it minimizes it significantly. You probably want to use less volume. So you want to use high calorie meals, high protein. You want to use fluid thickeners. Different interventions for people where those dietary changes are not enough and they're having recurrent aspirations. PEG tubes can be used. And again, just to mention, use PEG tubes, they reduce the risk of aspiration, but do not take it away. Remember, I talked about people can aspirate even from their own saliva. If they're lying in the wrong position, even if they have a PEG, they might still aspirate. And for people who cannot use PEGs for one reason or another, we can use central venous catheters for parenteral feeding. Other things that can be done to mitigate dysphagia are positioning and posturing of people when they are feeding to ensure that they do not reduce their risk of aspiration. Now, dysphagia there, I just wanted to mention that it's different from dysphagia, which I think the first presenter talked about. This is dysphagia related to swallowing. Next slide, please. So respiratory symptoms, this is the cause of the most deaths. As we talked about, is loss of ability to cough and, respiratory insufficiency from weakness of the muscles of respiration. So cough devices are being employed. Physiotherapists are helping out with this. There is a role of non-invasive ventilation. It's a whole big field, and there is strong evidence to show that it improves the quality of life for people. It improves survival. It also improves the respiratory parameters. Well, the respiratory parameter we use for monitoring mainly is our FVC, forced vital capacity, that we monitor for people who are having neurological deficits affecting the respiratory center. So I've put the indications there. But remember, with NIV, as some of you or most of you will have seen, NIV also has its downside. Many people are claustrophobic. They have anxiety. They cannot tolerate the NIV. Others, when they have it for so long, it causes, the mask causes ulceration of the face. So for people where they can't use NIV, or where NIV is being used, but the parameters are not improving, there is the option of tracheostomy. And there is evidence to show that it improves survival. There are other interventions like diaphragmatic muscle pacing that are being used by some centers to help to target respiratory symptoms. If we move on to the next slide, please. So dysarthria, again, as mentioned earlier, this is a disorder of, a word disorder. The patient knows what they are saying. Cognitively, they're okay, but the muscles that are needed to say what they need to say are the ones that are saying it wrongly. So remember, we talked about the Bulba Palsy and pseudobulbar. We talked about the raspy voice in the bulbar side or nasal speech versus the Donald Duck speech in the pseudobulbar. So patients, 80% of patients are going to get a dysarthria of some form in the course of their disease. It's also important to mention that not all the signs we've talked about, you will see them in one patient. For example, the patient that I introduced did not have any of these, did not have the typical weakness of the limbs or the upper limbs or the lower limbs, only had bulbar problems. The interventions, we can get speech therapists. They have a problem with speaking, so you can use speech therapists to help with their speech. If you remember, those of you who said, who have watched Theory of Everything, customized software like Stephen Hawking was using for his speech, these are all aimed at helping mitigating the problems caused due to dysarthria. If we move to the next slide, please. So others like muscle cramps, there's drugs that can be used, and muscle cramps are due to instability, damage to the motor nerves. There is pain. Now, as we said, motor neuron disease does not affect the sensory system. So taste, smell, they are going to remain okay. However, people get nociceptive pain, but not as opposed to, well, the word has gone, as opposed to nerve-related neuropathic, as opposed to neuropathic pain. So the pain is usually nociceptive, and the medications like NSAIDs, opioids are being used. So if you have less mobility, you're going to be staying on your back for a while. You're going to be compressing these nerves. You're going to get the cubitus ulcers, and these are going to give you nociceptive pain, not directly the MND affecting the nerves and giving them neuropathic pain. Because of the pressure that is compressed, or if you have limited mobility, you're having the cubitus ulcers, you're going to put a lot of pressure onto the nerves. So indirectly, there is a role actually for drugs that are used in neuropathic pain. Physiotherapy is also useful. It improves stiffness, helps prevent contractures, helps with the quality of life. And lastly, there, as I've put, neuropsychiatric disturbances, although originally it's not part of the spectrum, increasingly it is being accepted that it affects the cognitive side, the emotional side, especially like in pseudobulbar, but also without, even from the past, without affecting the direct, even if you have limited damage to the motor side of things. These people, you have an intact mind, you're unable to move. People end up getting depressed because of dependence, because they are unable to have independent activities of daily living, which causes things like depression. And there is a role for antidepressants, SSRIs, and seeing therapists. So it's from both sides. Next slide, please. So this is the most important bit of this slide. Often we know that MND is a terminal disease. It is progressive. Well, it's chronic, but different forms have different life expectancies. But palliative medicine is very important in these conditions. And things to consider are like advanced care planning. It's important to be realistic with the patients about what is expected, how much is left of them, whether they want to spend that time in hospital or home, quality home-based care, getting the community palliative services involved, they prescribe anticipatory medications, making sure MND people lose independence. So they are depending on everybody, but making sure that the caregiver burden is also addressed, making sure the family emotional, disturbances are also addressed. And lastly, when even people die, bereavement support is offered to these people. Next slide, please. So in summary, we've looked at respiratory failure being caused by a neurological pathology. We've explored other forms like of differential diagnosis and how we can use the signs, clinical features to have an idea of which neurological disorder is causing the problem. We've looked at some of the signs and how they come about that can be relevant in the assessment of a suspected MND. And we've also looked at the management of MND, which involves basically an MDT approach, multidisciplinary team approach from nutritional services, from physiotherapists, from neurologists, from respiratory consultants, from psychiatrists, from palliative team, everybody involved in the management of these patients. And thank you very much. Sorry that we've overrun a little bit, but I hope everybody has managed to take away something